In M0 CRPC, the patients currently do not have visible metastasis. In plain English, that means you can't see metastasis on a classic bone scan, you can't see metastasis on a classic CAT scan or bone scan. And so the endpoint of treating that condition is when the patient develops metastasis. We certainly know that men who have this M0 CRPC, if nothing is done, they're going to continue to progress that cancer, and eventually you'll see metastasis on those scans. The whole rationale behind these trials with apalutamide and enzalutamide and darolutamide are to use them in these men who have M0 CRPC to see if we can significantly extend the time till that patient has metastasis. So that's called, time to metastatic disease. And in all of the FDA regulatory requirements for using these drugs in the M0 space, the time to metastasis seems to be the endpoint that the FDA is most comfortable working with the pharmaceutical company, saying, look, if you meet this endpoint with this product, we're going to consider that for FDA approval. In other words, what the FDA seems to be saying is that time to metastasis in M0 CRPC is a surrogate for cancer-specific survival. The biological difference between prostate cancer that metastasizes and prostate cancer that doesn't metastasize is the $64,000 question that we're all wanting to answer, meaning why is it that a patient will have prostate cancer and live seemingly forever or for his entire natural life without developing metastasis, and the next gentleman who starts at about the same point develops metastasis in a couple of years? That we don't know, but we're working hard through molecular biology and molecular genetics to sort that out. Up until recently, we would have shrugged our shoulders and said, we have no idea. But I think we're on the verge of being able to potentially discover a whole series of prostate cancers based on their molecular pedigree. And I would imagine 10, maybe even sooner than that, we will start to manage advanced prostate cancer based on their molecular signature. And that molecular signature will help determine time to metastasis, or why one patient biologically is going to take for a long time to develop metastasis, and the next guy has a different molecular signature and may develop metastasis in a short period of time.
Prostate cancer typically metastasizes to the bones. It's a very bone-tropic disease. So 90% of the mets are to the bones, followed by lymph nodes, and then followed by liver and lung. So visceral metastases are typically those in the liver and the lung. People with metastases in the liver in particular do very poorly. And in some clinical trials, those patients were actually excluded from being tested.
When one looks at metastasis-free survival, we're looking at the prevention of metastasis and how that might correlate with overall survival. The hope would be that if we are giving a therapy that's going to prevent metastasis, that we might also be helping that patient to live longer. And it would probably or may not be effective to give that therapy if it only prevented metastasis and the death that followed after that was rapid. Well, the good news is that the studies that have been done by looking at several thousand patients on I think over 100 studies demonstrate that metastasis-free survival is highly correlated with overall survival, with a correlation coefficient of about 0.9, meaning that they're very, very tightly linked. And so that if we took a population where we were to improve their metastasis-free survival and a population where we didn't, we would expect that those who had the improvement in metastasis-free survival would also enjoy a longer overall survival. The future design of clinical trials in prostate cancer will learn a lot from current studies that are studying metastasis-free survival and are exploring the nature of therapies in the non-metastatic castration-resistant patient population. In general, we want oncology and specifically treatment of prostate cancer to become a more proactive endeavor. We don't want to be waiting for bad things to happen before we intervene with an effective therapy. And I think this is a really good example where an earlier intervention, by preventing a complication, may actually lead to an improvement in overall outcomes of a substantial margin for patients with this disease. As I think about the treatment of patients with prostate cancer, I have 3 goals that I summarize with the expression, the 3 Ps. I want to preserve quality of life, I want to prevent complications and progression, and I want to prolong life overall. And I talk to patients about that. And I think that the use of a treatment that's well tolerated in the non-metastatic setting by preventing metastasis is actually a really important, an effective treatment would be a really important step towards that preservation and that prevention and that prolongation of life.